Excellent. Thank you. So at this point, I'd like to open up the discussion for questions from the floor, and I would be very grateful if you could introduce yourself, your name and institution, and if you could word your commentary in the form of a short question. That would keep things rolling. All right. You can start us off, please.
I think, yeah, Fred Marsick. I'm a microbiology consultant from New Freedom, Pennsylvania. I've been in the area of infectious disease microbiology and have worked in academics in the last 17 and a half years, just prior to retiring last year. I worked for the FDA as an antimicrobial team leader microbiologist in the Center for Drug Evaluation and Research, and I have a lot of issues with the FDA programs. And I've also, my PhD thesis was on the use of antimicrobials in animal feed and the development of resistance and transfer to humans. And of course, we showed that back in after the Schwann reports and all this kind of thing. I was at the meeting in Philadelphia. I guess I'm not making a question out of this.
Something you'd like to ask the panel?
I was at the meeting in Philadelphia, and I wish them the best of luck, because this is just another money grab by a bunch of pharmaceuticals, academics, and this kind of thing, as to getting money for their research, because all they talked about was surveillance. They talked nothing about development of new antimicrobials and what we're going to do about the use, but surveillance. And I found that to be ignorant, to be honest with you, because I've seen at least 4 of these in my life, these kinds of panels, and they've gone nowhere. Okay, they just spend a lot of American money. The one issue I brought up, and which I was told to shut up about, was that there was nothing in there about surveilling the illegal aliens that come across our borders for diseases. I was actually told to shut up. And there was a government representative there. So I don't put too much faith in that. But I don't know, I'd just like to know what you guys are going to do. I'll put a question out. What are you really going to do to get the government focused in on the right track?
Great, well, thank you. Want to respond to that briefly?
Wow.
Make it brief.
I vote.
Well, wonderful. Next question.
That's right.
Actually, we have some at this microphone. Thank you.
Hi. Lynn Goldman, George Washington University, Milken Institute School of Public Health. So I used to regulate pesticides, and I heard Dr. Brownman talk earlier about all the analogies to ecology, and listening to you, I'm reminded of the marketing strategy basically for a pesticide, which is to make one that is as broad spectrum as possible and can be approved on as many crops as possible, applied on maximum acreage. And it occurs to me that the ecosystem of manufacture of antibiotics is very similar. It's a very similar strategy for the companies. And that we have a problem that's not just a problem of how NIH gives grants, and it's not just a problem of how expensive it is to bring something through the FDA regulatory process, but we have an entire system that is incentivized around bringing forth pharmaceutical agents that have very wide applicability, are going to be very widely used, and are going to make a lot of money. And there's nothing wrong with companies making money, but I'm thinking that we are here in Washington, and there are these strategies about prevention of antibiotic resistance, and there must be some ideas that you guys might have about how do we perturb the system, how do we move the system to be a system that actually values, the research, development, production of more narrow spectrum products.
Okay. Marty, you want to respond to that?
Yeah, I think your points are good. I think the problem is that clinical medicine has evolved in a way away from ecology. And I think all of us, and David for sure, espouse a much more ecological approach. And the ecological approach plus scientific evidence, we hope will get us back to a more realistic state.
Question for the panel?
Art Reingold, UC Berkeley. Several decades ago, I used to actually do clinical medicine, and I always found it extraordinarily difficult to talk people out of the therapy they thought they needed. And it was the path of least resistance was to give them what they wanted rather than to try and talk them out of it. So I'm just curious. I'm totally given up on the idea of changing the animal industry and their use of antibiotics, because we've had evidence that that's not a good idea for a long time, and it's been impossible to change policy around that. But I am curious, Marty, how you see us changing both expectations of patients and parents and performance of physicians around antibiotic use. The example in Dallas of giving antibiotics to that person with Ebola as he went out of the emergency room is just a perfect example of misuse of antibiotics. And furthermore, how do we do it without at the same time giving people the idea that infectious disease is good for you, natural infection is good, and maybe don't need vaccines?
Yeah. Sure, small question. So I guess I first would begin by saying that we could think of two different worlds in clinical antibiotic use, in the hospital and in the community. In the hospital, you have sick patients. And when people are sick, antibiotics often are life-threatening. However, unfortunately, life-saving, yeah, I'm sorry.
And life-threatening.
You're listening.
It was a test, right? I was just getting there because clinicians often think that if one antibiotic is good, 2 is even better, or 3 is even better. And when you look at hospital records, you find an overwhelming number of antibiotics in huge disposal. Now, in terms of the community, where many people with minor illnesses are getting antibiotics, or to prophylax against risks that are extremely low. This requires research and education. And once consumers understand that there is cost to antibiotics, now the parent with the child who's screaming thinks, if we don't get an antibiotic, my child is deprived. I don't really care about resistance in the community. That's somebody else's child. I care about my child. But if there is impact on their child in terms of risk of asthma or allergies or obesity or juvenile diabetes, I'm predicting that the parents of the future will say, I want a narrow spectrum antibiotic for if my child needs an antibiotic, I'd like a narrow spectrum antibiotic. We have to provide the diagnostics and the treatments.
Okay.
So another short answer is have all your patients read Marty's book.
So another short answer is some of us today are clinicians here today, but all of us here today are former or future patients, perhaps even current. So one thing we can do to make this different, to change this relationship, is to make sure that we are responsible about the way we approach our requests for treatment. Right? That's something I think is ignored when we talk about these sorts of issues. All right, so I think we're here now.
I'm Bill Hazard. I'm a gerontologist, geriatrician, interested primarily in sex differentials and longevity and why women live longer than men. So we talked about this in our section yesterday, but what came to the surface during the course of Marnie's presentation is an alternative fear that we have, and that is for the future of the aging population because of premature development of chronic disease, diabetes, and obesity. So they are not unlinked, and that's my primary interest, is understanding the obesity epidemic. But it goes beyond what I heard today, and that is there has been one theory proposed, perhaps not recently, that one of the trade-offs, perverse trade-offs of increased obesity, particularly in young women, females seem to deposit the fat more than the males at some of the feeding studies, is that the obese woman gives birth to a premature or early delivery. And so in the next generation, you may have small for day babies born who then grow up disadvantaged like their mothers, only even more so. Is that plausible, or have you looked at the offspring of some of your mouse studies and so forth?
Well, studies, there have now been 4 published studies about looking at cesarean section versus vaginal delivery. All 4 show an increased risk for obesity of the offspring from cesarean, and the studies vary whether it involves both elective or emergent C-section. But again, the C-section rate has just skyrocketed. We haven't talked about it today, but in the Netherlands and Sweden and Norway, the C-section rate is about 13 or 14%. In the U.S., it's 32%. 20 years ago, it was 18%. In Rio, it's 50%. In urban China, it's 50%. So we're doing this kind of medical intervention without considering what the cost. This is just at the time of the intergenerational transfer of the microbiota.
Are there multi-generational studies that have looked beyond a single transfer?
We have done a little work in mice where we have some evidence for anticipation, but that work is preliminary.
Thank you.
Hello. Question for the panel.
Hello. Hi. Michelle Berry from Stanford Global Health. Many of us work in low-resource settings where there are not wide, broad-spectrum antibiotics, no Z-Paks, and yet we're beginning to see an obesity epidemic. Is there a congruent theory or hypothesis? I realize obesity is multifactorial, but it's a very interesting observation.
So there's recent CDC data that counties with a lot of poor people have more antibiotic use than counties with rich people. And same for education. This is work by Laurie Hicks and colleagues. And that suggests that in the United States, at least, poor people are getting more antibiotics than rich people. And that's been one of the mysteries in the obesity epidemic. Hicks's work also shows that women are getting antibiotics about 40% more than men, which is another point. Most of the antibiotics we use, as David said, really are broad spectrum. There are very few narrow spectrum. There are some super broad spectrum, especially macrolides. But we are, all the antibiotics that have been available for the last 50 years are essentially broad spectrum.
This is not happening in Zimbabwe or Liberia. It's very small spectrum antibiotics, and yet we're still seeing obesity.
Antibiotics are everywhere. Yeah. In China, they're using 2 to 4 times as many antibiotics as we're using because they're not regulated. You can go to a farm, you don't feel well, people take antibiotics. In China, hospitals are incentivized to put people on IV antibiotics if they don't feel well.
So in respect to your particular situation, I have a colleague who works in that area on poultry infections, and they feed the cows and the chickens antibiotic-laced food, which shocked me because I thought that would be expensive, but it's not. To them. I guess they get our leftover drugs or something. So I think there's a lot more antibiotics in the environment than just what's prescribed in the clinic.
Yeah, and you already said this, but there are a lot of countries where the tracking of antibiotics is very poor. Yeah. Right? In most, what we consider resource-poor nations, antibiotics are over-the-counter medications, and there's no tracking. You can buy it like you can buy aspirin, probably cheaper. In Peru, I think kids below the age of 13, you can get antibiotics for free. And so I respect the point that there may be, confusion with obesity and what antibiotics those particular settings might be getting, but antibiotic use is even greater in many of these countries than we have in the U.S.
One thing this question reminded me is that there's microphones in the back as well as the front. My apologies. So in the back here, could you please ask a question for us?
I'm Alan Hyman from Columbia University. To Dr. Blazer, I guess, as with the surge in obesity, and partly accounted for by the use of antibiotics, what about the tremendous increase in autoimmune diseases that we now see? And what is the current thinking about the relationship between antibiotic use and autoimmune?
Well, so it's becoming increasingly clear that the early life microbiota are helping shape the nature of immune responses. David referred to this, and we think of that the microbes have evolved to help us choreograph immune responses. And we're perturbing the microbial populations at the time that they're training our immune system. And I showed one slide very briefly showing how so many immunologic genes are changing as a result of antibiotics in mice. And there's a lot of work in experimental models showing perturbation in early life immune responses, which are then carried on now for long periods of time. So all these epidemics are coming about more or less simultaneously. And you can make the hypothesis that this early life perturbation is having an effect.
We have time for one more quick question. I think you've been waiting for a while. Could you ask
Thank you.
Question?
Harry Hyman from Morehouse School of Medicine and a former Robert Wood Johnson Health Policy Fellow. I live in Atlanta. As you know, the South doesn't have particularly good health outcomes, so I was intrigued by the CDC obesity mapping and the tension between, on the one hand, we need to worry about inappropriate antibiotic prescribing, but actually 80% plus is what's coming out in the environment. So what do we know about the microbial environment of those populations? I'm thinking particularly low-income racial and ethnic minority that experience not only the highest obesity rates, but also correlating chronic disease and other problems. Well, what do we know about the antimicrobial environment for those populations and how it may be different from others that aren't experiencing the same degree of morbidity and mortality?
I don't think we know enough, and it's a very important question, and that we can look at groups that have different rates of important chronic diseases. I think my emphasis would be to look at children, to look on the front end of the causal side.
Thank you. Unfortunately, we're out of time for questions. Please, I'm sorry we weren't able to get to all of you today. Please join us at the break if you have more questions for the panelists. And please join me now in thanking them for an excellent workshop.
Thank you.
Let me just add my thanks for a wonderful discussion. You were all incredibly thoughtful. There are people here who can make policy decisions, who do make policy decisions. They are listening. You know who you are. I do, and I don't mean this in a flip way, I do think that, at least in my maybe shorter lifetime, this is a time when there is an unusual amount of attention and sensitivity to these issues. Congress is actually listening, if you can believe that. There have been some bills passed. Go forth and carry this message and engage, because I think there are opportunities. Thank you for your attention.
Thank you. That was great. Thank you.
I'm going to turn the podium back over to Dr. Zhao.